Hello, everyone from St. John's, Newfoundland and Labrador. My name is Janet Herron, and I am an Alumni Engagement Officer at Memorial and your host for today's event. I'm here with Dr. Kathy Balsom of the School of Pharmacy's Medication Therapy Services Clinic, who is going to explain what we can do to ensure our medications are serving us well and how to be a proactive member of our own healthcare team. I know those of you attending can't see who else is in the room for the event, but we have a full house, over 150 registrants, and more joining every second, 56, 60 people here now, and we are delighted about that. And I'm sorry about the little technical glitch at the beginning there, but I think we've addressed that now. We will begin today's event, as always, with a land acknowledgement. We acknowledge that the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups, and we acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We encourage everyone to reflect on these lands from where you are located and the Indigenous peoples for whom these lands are traditional territory. So, welcome to our event today. At the Office of Alumni Engagement, we are focused on offering many ways for you to connect with Memorial from anywhere in the province, the country, and the world. And we're working diligently to foster opportunities for alumni to celebrate their connections with Memorial and with each other. MUNalum 101 was born out of the need to reach out to alumni during the first few months of the pandemic. It has since evolved to become a cornerstone of our alumni engagement activities, offering the latest information on key topics from Memorial University's own experts. Embarking on new and exciting ways to build relationships within our Memorial community is vital to our evolution as an institution. So please consider getting involved with our programming. You can be a mentor with 10,000 coffees, discover opportunities to meet up with expats through Global NL, and our online book club Coastlines features a stellar selection of Newfoundland and Labrador authors, most of whom are Memorial alumni. And you can find out more details about all these programs on our website, www.mun.ca/alumni. Thank you so much for joining us today for our discussion on how best to manage our medications. Just a few housekeeping issues. A brief Q&A will follow the presentation. I will be monitoring the Q&A function, which you will find at the bottom right-hand side of your screen. So please try to keep your questions short, and I encourage you to post questions as soon as possible. Please don't leave them to the last minute, as we have a full program and we'll only have a limited time to take questions. Attendees are unable to unmute your microphone or turn on your video, but you can communicate with other attendees and Dr. Balsom through the chat, and myself. So you can put your questions either in the chat or in the Q&A. We are streaming live, but this session is also being recorded, and all those who registered who will receive a link to the event in a follow-up email. A final note that please understand that Dr. Balsom is not able to answer personal questions regarding your own medication issues in this particular forum, but feel free to book an appointment at the MTS clinic if you do have such questions and you would like to follow up. It is my very great pleasure to officially introduce our special guest today. Dr. Kathy Balsom received her B.Sc in pharmacy from Memorial in 2011 and began working immediately as a community pharmacist in St. John's. She received her doctorate of pharmacy from the University of Florida in 2016 and came to work at Memorial's School of Pharmacy as a clinical pharmacist at our Medication Therapy Services Clinic. She is an advocate for deprescribing and is passionate about ensuring patients are taking the right medications for them. When not working at the MTS clinic, she can be found moonlighting behind a community pharmacist counter, hiking her dogs, or chasing her toddler. So I'm going to pass the presentation and the presenter duties over to Dr. Balsom. I'm just going to load up her presentation now, and I am going to give her the controls. And I'm going to mute myself, and I'll come back at the end.
Excellent. Thank you so much, Janet, for that lovely introduction. Like Janet said, I'm Kathy, and I'm a pharmacist here at our MTS clinic at the School of Pharmacy. And I'm going to run you through um, how to really become engaged in your medication taking and become an empowered patient, and just give you some facts. And hopefully, at the end of this, you'll start to question the medications you are taking. And I'd be happy to help in that sense if I can. So, a lot of people don't know about the MTS clinic, or the Medication Therapy Services Clinic, that is offered by the School of Pharmacy at Memorial. So we do offer one-on-one appointment-based pharmacist consultations in our private clinic environment, and it's at no cost to the patient. So we actually work alongside other healthcare team members like doctors, nurses, community pharmacists, but also occupational therapists, community health supports, all those different sorts of people on your team to really provide optimal care for patients with complex drug-related needs. So we are funded through Memorial School of Pharmacy, which allows us to see clients at no charge. And we do evaluate everything that we do at the MTS clinic. So not only are we here to improve patient care and improve patients' medication taking, but also to generate evidence to help to inform health policy and service delivery in the future. What we can provide is we can kind of help you get a full overview of your medications and start to look at them holistically. How are they interacting with each other? How are they helping treat the medical conditions that you may have? We also like to help, of course, with chronic diseases. So whether it be diabetes, COPD, hypertension, we can definitely help you, navigate those conditions with your medications, and also just provide education in general. We can certainly make complicated drug regimens easier. I've had multiple people that take multiple medications, and sometimes it can be really complicated on how best to take them and whether or not they can be taken together, if they need to be separated from other medications or food. We're here to make that easier. We're also here to help with side effects, whether or not a medication, you're wondering if something that you're experiencing could be a side effect of your medications, or if you know there's a side effect related to your medications that you're experiencing and how you can manage that. And we're also here to run interaction checks on all your medications, whether it be other prescription medications, herbal medications, over-the-counter medications, and sometimes even foods, and how they can interact. And also, of course, we're here to provide education, whether that be on your medical conditions or the medications or anything in general when it comes to that. That's what we're here for. So our process at the clinic, a patient will get referred oftentimes by a physician, nurse practitioner, community health supports, occupational therapist, or patients can actually self-refer as well by simply just kind of picking up the phone and booking an appointment and saying they'd love to have an opportunity to sit down and chat with one of our pharmacists. So then once a patient is referred, we do a chart review so we can access lab values, online clinical documentations, any reports that are pertinent to your medications. And then at the appointment, we actually sit down typically for a full hour, and we go down through everything. So social factors that can affect medications, your medication lists in detail, getting really a sense of all of the medical conditions you may have, and all of the interplay of everything all together. We're here then to communicate any education kind of on the spot that we can provide. And then we also kind of take it away and really dive deep into the literature and the evidence if we have to, run interaction checks, look at all of our resources, and really come up with the best plan to help you navigate any of your medications, and come up with any recommendations that we would make to better service you in terms of changing any medications or deprescribing, and then we send that into a recommendation letter to the prescriber if needed. We don't often change anything kind of on the spot, but we work with your healthcare team to make sure that your medications are best serving you. So one of our clinic programs is our deprescribing program. So this is kind of when I get to feel like a superhero. I think to some people it may be odd to hear a pharmacist talk about stopping medications or deprescribing or taking away medications that may no longer be necessary. And I mean, I studied medications for, 8+ years. So I've certainly can appreciate the impact and, the helpful, how helpful medications can be in treating medical conditions. But I can also appreciate some of the prescribing cascades that we've gotten into, where we're treating side effects with more medications, et cetera, et cetera. So certainly it may seem odd, but I'm certain that you'll understand where I'm coming from with deprescribing at the end of this presentation. When we look at the MTS clinic, I just wanted to present kind of some of the demographics because this is from a local perspective, of course, here in St. John's. So when we look at the patients that we've seen here at the clinic, our median age is 69. Most people are between 58 and 76, but we've certainly had younger and older. 59% of our patients are female. And the average number of medications that patients come to us on is 11, but it, is typically between 7 and 14. But again, I've had people as little as, 1 or 2 medications, but I had potential issues with those. And then as high as, 25 medications. So the average or the median number is 11. And when we look at the drug therapy problems identified, so these are things that we think that we could help with and provide recommendations in order to really make sure that it's beneficial for the patient. The median is 4, so it typically ranges from 2 to 5. And about half of our assessments actually result in a deprescribing recommendation. So 56% of our patients actually had recommendations where we would say to actually come off of a medication altogether. Maybe it's decreasing the dose or switching it out to a safer medication. When you look at that pie chart there, we do kind of categorize all of the drug therapy problems that we identify. And the biggest piece of the pie there being 25.1% is actually that there was no indication for this drug, which means a patient was taking a medication that there was no longer a need for it, whether or not that condition resolved or it was an ineffective therapy that was then replaced with something that was more effective. So you can see that, certainly a common problem that we identify there here at the clinic. That being said, of course, we're not just taking away medications. The next biggest piece of the pie there is that there was actually an indication for a new drug that should be added. So we are adding medications and we certainly see the benefit of them, but I'm going to talk today a lot about deprescribing as well. So what is deprescribing? So deprescribing is basically stopping prescribing or deprescribing. So we consider that to be stopping a medication altogether, but also not just stopping a medication. We could be talking about decreasing the dose of a medication or switching to a safer medication. So deprescribing kind of encompasses all three. When it comes to deprescribing, there are a network of people who are very invested in improving prescription medication use across our country. And the Canadian Deprescribing Network kind of brings us all together. So they have a lot of really good resources. And this is an image that they have on their website. And I found that their definition really encompasses what I'm trying to get at. So what is deprescribing? Deprescribing is the planned process of reducing or stopping medications that may be no longer of benefit or may be causing harm. And the goal here is really to reduce the medication burden while improving quality of life. So we're not just going out there and saying, oh, you should stop that, stop that, stop that. It's a planned process of reducing or stopping. It's certainly in a collaboration with the rest of the healthcare team. So you can see there, deprescribing should be done in partnership with healthcare providers. There may be reasons to continue taking certain medications or reasons why close supervision is needed when you're stopping. Some medications can't be stopped cold turkey. They really need to be reduced over time. And of course, medication should not be stopped without first consulting with a doctor or healthcare professional. So even in our recommendations, when we're sitting down with our clients or patients, we will talk about how we would be interested in deprescribing and putting that recommendation forward to the prescriber. But we never recommend patients kind of stop it without us really consulting with the prescriber to begin with to make sure that there's not something that we're missing here and why, if there's any reason why it should be continued. So we work together as a team in that regard. So why deprescribe? I think we can all appreciate why medications are needed to really kind of improve quality of life, treat symptoms, treat medical conditions. So when we're talking about deprescribing, it may be a little bit more kind of unknown about why you would even consider this. And of course, we know that taking medications is necessary for health, improving symptoms, or prolonging life expectancy. However, as we get older, the benefits and risks of medications may change. And the risk of harmful effects and hospitalizations does increase when you take more medications. So as you get older, you typically get more medications maybe added on board. And as we add more and more and more, of course, there's a risk of those interacting with each other or stacking up in terms of the side effects or the harmful effects that they may have. And of course, older women are typically more susceptible to adverse effects of medications and are more likely to be prescribed risky medications. So just something to think about. And also 71% of Canadian seniors actually said that they were willing to stop a medication if the doctor said it was possible. So it is kind of a new way of thinking about our medications. Of course, for many years, we just kind of added and added and added. But now I think it's important to think about when a medication should be stopped or maybe decreased. And of course, seniors are on board. When asked, they did say that they would be acceptable to that recommendation if it was possible. So this is just a testimonial of a recent patient who had come to the clinic. So this particular patient said, "I always felt I was taking too many pills, and my doctor mentioned that I could go to the MTS clinic, meet with a pharmacist, and discuss my medications. My wife called, booked me in, and I'm so glad she did. I was overjoyed. I learned a lot, and now Dr. Kathy is working with my family doctor to help me come off of 3 medications I no longer need, and she switched my diabetes pill to a safer one for me." So you can see there that, oftentimes people are on more medications they may need at this time. So I wanted to give you guys just an example. This is Lucy, just kind of an example of a patient that may come to our clinic. And it may, represent somebody that you know, or maybe even you yourself. So when you look down at our medications, not that they may mean anything to you, but starting at the top there, she's got clonazepam. She takes that 4 times a day for anxiety or nerves. Donepezil is for memory. She takes rabeprazole for her stomach, metoprolol for her heart. She takes ramipril and hydrochlorothiazide combination pill there for her blood pressure. She takes glyburide and metformin for diabetes. She takes loperamide as needed for diarrhea. She takes naproxen as needed for pain. She takes oxybutynin for her bladder. She takes iron pills for iron supplement. She takes Docusate for her bowels. She takes rosuvastatin for cholesterol, and she takes an aspirin once daily for cardiovascular protection. So this may seem like a lot, or it may not seem like a lot to you. It's all relative. So this is kind of pretty typical of a patient that we may see in the clinic. So she's wondering, do I really need all of these medications? I need your help. So we'll kind of come back to it. So here's a bit of a pop quiz. So here's where I want you to write in the chat if you have any input here, but I want to ask you, what portion of Canadians over the age of 65 do you think take at least 5 different prescription medications? Do you think it's, 10%? Do you think it's 20%? Do you think it's 40, 50%? What do you think? Throw some suggestions there in the chat to how many you think are taking at least 5 different prescription medications. 35%, okay. Anybody else? 70%, okay. Yeah, so that's at least 5. So now, yeah, 70 to 75%. So now think about, I will reveal the answer on the next page, but I didn't want to get ahead of myself because I wonder how many you think take at least 10 different prescription medications. So our guesses for 5 medications range from 35 up to, 80%. And if we look at those that take 10 prescription medications, we've got 20%, 35, so we certainly think that there's quite a lot of people. 10 medications may seem like a lot. We've got somebody that gets 75%. So when we look at Canadian medication use, 2 out of 3 Canadians, so 66 or 67% of Canadians over the age of 65 take at least 5 different medications, and 1 out of 4 take at least 10. Okay, and that's over the age of 65. So it's quite a lot of medications. So, like we said, 66% take at least 5 different medications, and 27% take at least 10 medications. And this actually increases as your age bracket increases. So 20% of seniors 65 to 74, 32% of seniors age 75 to 84, and once you get 85 plus, is 40% of seniors age 85 plus are taking more than 10 medications. So like I mentioned earlier, kind of as you age, you're more likely to get more and more medications stacked on. So I want you to start to think, is that because something wasn't working, and then instead of stopping the medication that wasn't working, did a new medication just get added on to the ineffective one? Or was there a side effect caused by a medication that you ended up having to get another medication to treat the side effect of the previous medication without actually considering whether or not that medication could have been changed to one that didn't cause that side effect. So these are the kinds of things that are kind of happening in practice that we really want to be more empowered to question and really consider what's best for each particular patient. So I am a big advocate or a big supporter of Newfoundland, and I think that there's a lot of things that we're really good at, but unfortunately, we're really good at being bad at medications. When it comes to picking medications and our use patterns of medication. So, if you look across the country, this data is a bit old. It's coming from about, I think it's 2017 data. So it's a little old. Unfortunately, I don't think it's been updated. Of course, with COVID, a lot of our data has changed. But when we look here, the orange percentages shown here is the percentage of seniors chronically using proton pump inhibitors. That's one class of medication. And the red is showing the opioids. So when we think about the orange, you can see there that Newfoundland has 29% of our seniors that are using proton pump inhibitors chronically. So these medications are very commonly used in Newfoundland, not only in our seniors, but I think across all age groups. And proton pump inhibitors actually stop your stomach from producing too much acid. So people who get heartburn or reflux after they eat, they'll often be prescribed a PPI for that. There are some people that need to use PPIs long term. But the majority of people that are using them here in Newfoundland are just using it for simple reflux or GERD. And in that case, it should only be used for 12 weeks. But of course, oftentimes we are started on a medication and just gets continued and continued and continued. No one really kind of questions when to stop it or when would be the right time. Again, like I said, some people are really indicated for the continued use if they've got proven esophagitis or ulcers, or if they're on medications that cause damage to their stomach, there's certainly a reason to stay on it. But this is why it's really important to kind of look at patients at an individual basis and determine whether or not they need it. And you can see Newfoundland has, 29% of our seniors are chronically using these medications compared to over in B.C, there's only 8%. So, I certainly think that shows and there's quite a large difference there in prescribing patterns and how we manage simple reflux. And are these medications the best ones? I'll get into detail a little bit more about the risks of these medications after. And of course, you can see opioids across the country. It's pretty close. It's not as broad of a range in terms of use, but we are one of the highest provinces in opioid use as well. And I don't think I need to kind of explain in detail the risks of opioids, but of course, seniors are more susceptible to the side effects of opioids, like the cognitive impairment, fall risk, drowsiness, dizziness, those sorts of things. And also, so the other one I want to talk about is benzodiazepine. So we are the second highest use. We have the second highest use of seniors of these medications in the country. So you can see there were 21%. Ontario is actually only at 7%. BC is only at 7%. Saskatchewan's at only at 5%. But we have 21% of our seniors chronically using benzodiazepines. So these are actually sedatives. Oftentimes, our seniors may refer to them as their nerve pills. Maybe they're for anxiety, but we know they're much safer medications out there than benzodiazepines. They're often used for sleeping as well. So they're a commonly used sleeping pill, but we can certainly see that our province is, a top rated in this medication use of our seniors. So when we're thinking about deprescribing, I want you to start to think of each of your medications and whether or not they really need to be on there. So of course, any medication could be potentially inappropriate in a person, but it all kind of depends on what it's being used for, how it's being used, etc. So the Canadian Deprescribing Network is focusing on a couple different medications to start with. And we know that these medications can be risky and should be considered for deprescribing in seniors. So the benzodiazepines are the first ones that's listed there. Like I mentioned, we have quite a high rate of chronic use of those in our seniors. And like I said, these are often used to treat insomnia or other sleep problems. Some common names that you may have heard are diazepam, Valium, lorazepam, which is the brand name Ativan, or alprazolam, which is the brand name Xanax. So these can be physically and psychologically addictive and are best stopped gradually. So these, like I said before, some medications can't just be stopped cold turkey. These ones can certainly cause issues if you are to stop them abruptly. So this is when we kind of start to wonder, is there anything that we could substitute it for? Can we work with our patients to come off of them quite slowly? The risks of these are memory and concentration problems. So of course, something that our seniors aren't are probably not willing to kind of put at risk. Daytime fatigue, falls, and fractures. So I'll talk about a bit about how serious falls can be at the end, but falls are certainly a problem. Also, they definitely put you at higher risk of motor vehicle accidents, and there's actually some Scandinavian countries that took away the driver's license of seniors that are prescribed these medications because they're so risky. And of course, we don't want to just stop a patient's sleeping pill without offering other suggestions. So we help to work with people to see if there's other prescription medications that could be used, or also to help with them to really initiate proper sleep hygiene, relaxation techniques, and other things. So perhaps there's not a need for medication. The proton pump inhibitors are another risky medication class that the Canadian Deprescribing Network is looking at. So like I said, these are typically used to treat heartburn, reflux, and ulcers. In some patients, there is definitely a need to continue them lifelong or long term at least. But in the majority of our patients, we certainly see that they should only be used for 12 weeks if it's for simple GERD and no other issues. So the risks here are hip fractures, which kind of seems silly to think that your stomach pill can actually put you at risk of falling and breaking your hip, but that's certainly true. There's an associated risk there. This primarily comes because when your stomach doesn't produce acid as a result of these medications, you actually can't break down some of your foods properly, and you won't get the absorption of some of the important nutrients from your food. So you can go low in magnesium when you're on these medications, which can impact the bones. So there's all kinds of risks there associated. So we often suggest other ways to manage heartburn and reflux, whether it be other prescription medications, whether it be through diet or over-the-counter medications like Tums, which are much safer. And then the last one that's listed there is glyburide, which is a particular medication that's used for diabetes, but we know it can cause really serious drops in blood sugar, which can cause people to have dizziness, risk of falls, anxiety, feelings, those sorts of things. So there's definitely safer medications out there when it comes to diabetes, especially because diabetes is constantly changing and there's always new medications coming out. So we work with people to switch them to other medications, or perhaps get rid of the medication if we can manage the sugars through diet. So those are just some of the drugs that we target, but at the clinic, we sit down with each of our patients and go through each medication individually to talk about what are the risks and benefits and whether or not there may be an opportunity for deprescribing. So I alluded to prescribing cascades earlier, so this is really common. So I think this cartoon does a really great job of showcasing it. So it says, well, the white pill lowers my blood pressure, but they make my legs swell. The yellow pill lowers the swelling but causes me to pee. The blue pill stops me from peeing but makes me confused. The tan pill improves my memory but makes my nose run. The pink pill stops my nose from running but makes me sleepy. The orange pill wakes me up but increases my blood pressure. So the white pill lowers my blood pressure, but. So this is actually, a pretty common thing that we're seeing in practice. And this is an example of a prescribing cascade that actually Lucy, the patient that I introduced earlier, could actually be experiencing. So you can imagine, she's getting older and she's starting to have joint pain because she was, really active her whole life, and she gets arthritis in her knees. So the doctor prescribes naproxen. So that's Anaprox or Aleve to help with the anti-inflammatory effects and help with that pain. So this could aggravate blood pressure. So her blood pressure starts to spike. So she could get added on a medication for hypertension. So the that's a combination ramipril hydro pill for blood pressure. And that hydro part actually makes your blood pressure go down by causing you to lose more fluid through peeing more often. So this could lead to overactive bladder. So then, of course, Lucy got added on oxybutynin for that. But oxybutynin can cause cognitive issues, drowsiness, and dizziness, and also memory issues. So she got added on a pill for the memory issues. You can also see at the top there that the naproxen can lead to heartburn because it does aggravate your stomach. So ribeprazole gets added on. And because the ribeprazole is a PPI, she has lowered absorption of the iron in her diet, which leads to iron deficiency, which she gets added on ferrous gluconate, which can cause constipation, so she gets added on docusate. And throughout all of this, you can see a lot of the medications there, were added to treat side effects related to previous medications. And they can cause side effects themselves. So you can see their dizziness and drowsiness, and she ended up with a fall. She broke her hip and she ended up hospitalized. So you can see there's certainly interplay when it comes to a lot of medications. So another bit of a pop quiz here. So when you look at seniors and inappropriate medication, so we're kind of thinking of medications that may not be the best choice in seniors that we know have a lot of evidence to show that they can be risky when they're used in seniors. Would you say it's 1 in 2 medications, 1 in 3 medications, 1 in 4? What are some of your kind of estimates of what portion of medications commonly used in elderly people may be considered inappropriate? 1 in 3, yeah, 52%, pretty precise. 1 in 2, 30%. So it's actually 1 in 5. Certainly there are appropriate medications as well. I want to kind of hone in on that. I'm not harping on all of medications. But 1 in 5 drugs commonly used in older people may be inappropriate. Okay. And again, this increases as you age. So when you look at those over 65, 31% of males will fill at least one risky prescription in Canada, and 42% of females in that age range. When you get over 85, it increases. So 39% of males over the age of 85 will fill at least one risky prescription, and 47% of females over the age of 85 will fill at least one risky medication. So you can see how that does increase as you age. So we were involved in some research at St. Patrick's Mercy Home. So I suspect that a lot of the people here in the room today are familiar with St. Pat's. So it is a long-term care facility here in St. John's, and it's right next door to where our clinic is located, off of Elizabeth Avenue here in St. John's. So they heard that we were out there trying to do some work in deprescribing. They said, wow, like we would really like to kind of partner and see what we could do to help our residents. So in order to kind of do it right and make sure that we didn't, go in and take away medications that may be helpful for people and do any damage, we wanted to kind of look at it. And we took one floor and we took half of the patients that lived on that floor, and we said, okay, we're going to do a very intense medication review like we would at our clinic. So, and then the other half of the residents that were there would just kind of carry on as normal and still see their physicians as normal, but they wouldn't have that kind of really intense medication review done by the pharmacist. So at 3 months after the pharmacist was involved, we actually saw the residents have an average decrease of between 2 and 3 medications. So 2.45 medications per resident was actually stopped at 3 months. And at 6 months, it actually kind of continued. Because like I said before, we don't necessarily just go in and stop everything abruptly that we think is inappropriate. What we do is staged approach. We take away one thing at a time to make sure that we're not kind of rocking the boat or causing any problems. And at 6 months, almost 3 medications per resident were stopped. So we actually concluded that the deprescribing intervention successfully reduced the number of medications taken by the nursing home residents, and we found that there was no impact on cognitive function or survival. So, I was kind of hoping that we were going to go in and really improve cognitive function once taking away all these medications, because oftentimes you can see an improvement in cognitive function when a medication is discontinued. But we actually saw no negative impact in any of the deprescribing recommendations at the home. So it was certainly seen as something that was beneficial for the residents. You can imagine, taking 2 or 3 less medications per day was really impactful. So another thing that medications can certainly impact is your risk of falling. So I think some people think of, a trip and a fall is not a big deal, but it certainly can be. So this lady here was actually my grandmother. So Funny enough, my nan was in her late 70s, and when I got in pharmacy school, and I remember calling her, and I was so excited to get in pharmacy school, and she said, "I don't know why you're getting into that tablet racket. All anyone needs is a laugh." So she was someone who didn't take any medications, hadn't really seen a doctor actually in quite a long time, had no complaints, didn't take any medications. She was the first one to the dance floor and the last one to leave it. She was a party animal. She was, full of life. All of a sudden, one day, she got abruptly confused, a bit delirious, and she was sent into the hospital. And unfortunately, I think the last alumni presentation was on ageism, and I think that this was a little bit of an impact factor here, because she was turned away in the emerge. They kind of just did a quick once over and said she was fine. She was just confused because of her age, and they sent her home. So the next day, actually, my uncle found her on the ground. She had fallen and broke a hip. It turns out that she had a urinary tract infection that was misdiagnosed. And as a result, that's where the delirium and stuff was coming from. But she fell out of nowhere, no medical conditions, and she fell. She ended up in long-term care, and she died within 3 years. And I think that fall changed her life dramatically. So even though her fall wasn't related to medications, it wasn't a result of medications. Medications have such a large impact on fall risk for our elderly patients and our seniors. And we really want to make sure that if there's a senior who is falling, we make sure that the medications aren't what's contributing. So when it comes to falls, like I said, one big problem medication overuse in seniors is the increased risk of falls. So falls account for 9% of all emergency department visits of our seniors. And some medications can actually increase the risk of falling by 50%. So the benzodiazepines that I mentioned earlier, which are typically used for, nerves or anxiety, or often as sleeping pills. Antipsychotics, long-acting sulfonylureas, which is like that the glyburide that I mentioned for diabetes. These medications can increase your risk of falling by 50% because they do cause issues with concentration, drowsiness, balance problems, dizziness, those sorts of things. So certainly an impact. And when you think about how serious a fall can be, 30% of seniors that are living, in the community in their own home will be institutionalized within a year if they fall and break their hip. So oftentimes this is because their mobility, they can't get around as well. They can't do a lot of the activities of daily living that they're used to. And they lose their independence in a lot of sense. And 20 to 30% of hip fracture patients actually die within 1 year. So I think a lot of the seniors that I kind of chat with don't really think that falls are that important. But once you have a fall that, you certainly fall and break something, it can change your life dramatically. So we always look through medications and really kind of consider whether or not they could be contributing to your fall risk, and then see if we can deprescribe them or switch them to a safer medication. Another thing that we do is cognitive impairment screening. So commonly used medications, whether they be over-the-counter medications or prescription, can cause a range of cognitive impairments, from simple, sometimes confusion, to full-on delirium, and they may even mimic dementia. So these are things like opioids, your narcotic painkillers, benzodiazepine, like I mentioned, and anticholinergics, which include a lot of medications, a lot of prescription medications, but a lot of over-the-counter medications as well. And some people will take over-the-counter medications and they think that they're safe because you can buy them without a prescription. But in some people, they are not. So things like Benadryl, Gravol, I think a lot of people will be able to kind of associate the drowsiness and some of the confusion that they get. But as you get older and, our bodies don't clear these medications as well as they used to, or metabolize these medications as well as they used to, they can accumulate. And our seniors are more susceptible to these side effects. Sleep aids over the counter, when you look at Sleepies, that's actually the same medication as Benadryl, just remarketed. Tylenol PM, they actually have a sleeping medication component. Oftentimes something like Benadryl is in there to help you be able to sleep through a cold, but they can also be pretty detrimental to our seniors. And oftentimes, if memory impairment is caused by medications, it will actually go away when the medication is stopped. So we've actually seen memory actually improve when we've stopped some of the medications that could be contributing to cognitive impairment. So again, something that we consider when we're meeting with our clients and our patients. So what can be done nationally? Like I mentioned, there's the Canadian Deprescribing Network, and I encourage you, if you're interested, to check them out online. They're a group of healthcare leaders, academic researchers, and patient advocates who work together to promote appropriate medication use across Canada. So I'm a member, you can be a member. They have great resources out there for patients, families, anybody who's looking to really encourage more appropriate medication use. And the goals are to reduce harm by raising awareness and cutting risky prescriptions for seniors, and to promote health by ensuring access to safer drug and non-drug therapies. So provincially, we actually have a group of, engaged healthcare providers and public advocates involved in Safer Meds NL. So this is a great resource that is here, of course, in Newfoundland, and you can certainly jump on their website. There's lots of information there for patients. It says, "Do I still need all of my medications?" So there's some really good resources there on, what to consider when you're really evaluating your medications, things that you can help. If you've got someone that that's falling a lot, perhaps it's related to their medications, I encourage you to check out their website. It's really a great resource. And like I mentioned, Safer Meds is a great resource. The Canadian Deprescribing Network website is there. The Canadian Deprescribing Network also has really great patient brochures on how to get a good night's sleep without medication, all kinds of things. So I really, really encourage you to use those. They've also got a really great patient brochure on PPIs and how to, successfully look at other ways of managing reflux and heartburn that don't include these medications. And of course, the Medication Therapy Services Clinic. So I would be quite happy to meet with any of you that may be concerned about your medications, or I'd be really encouraged if you could pass along this information that we exist to your family members, your friends, anyone that you know is on quite a lot of medications, even if you're not even concerned that there's any issues. Sometimes it doesn't hurt to have someone, a professional, go down through the medications and really provide education. Perhaps you still need all of your medications, but perhaps there's an opportunity there to switch something to something that's more effective or less harmful. So our website is there, mtsclinic.ca. I'm going to share our phone number at the end as well. So I just want to circle back to Lucy so you can remember this is her medication list. We talked about that prescribing cascade. So some of these medications came as a result of other medication side effects. So this is someone that would be, similar to somebody seen at the clinic. And after they were seen at the clinic, this is something, this kind of may represent some of the changes that have been made. So you can see some of the medications were actually stopped. The green ones were actually medications that were switched from, more harmful medications to safer medications. And you can see there some of those medications were able to be removed because the medication that originally caused the side effects was optimized to something better and not as harmful. So you can see there's certainly opportunities for deprescribing in a lot of patients. So I hope this was helpful. I hope it just changed your perspective on managing your medications and really kind of looking down through all your medications more critically. We're certainly there to help you provide any education that you may need and answer any questions that you may have. We're certainly looking forward to helping you or your family or your friends with your medication therapy needs. So here's our website, mtsclinic.ca. You can find a little bit more information. Our phone number is there as well. Like I said, you can self-refer. So if you yourself want to call and book an appointment, you think, it wouldn't hurt to go down through your medications with myself or another one of my pharmacy colleagues, by all means, all you need to do is call and book. We are seeing people back in person now. For a while there, we were just seeing people virtually, but our virtual means is still available. So if you live outside of the overpass and you live on the West Coast or Labrador, anywhere in the province, by all means, we can arrange to see you virtually. And in the event that you're in a community, we've run into this, especially in some of our rural areas where internet is a bit unstable, we can certainly do it over the phone. So, don't hesitate to share our number far and wide if you know of anyone that we may be able to help.
Thank you so much, Kathy. Dr. Balsom, sorry. I shouldn't call you
No
Kathy.
problem.
That was just incredibly informative. I have to say, we often don't know what we don't know.
Mm.
And so now we know about deprescribing, we know about prescribing cascades, and we know now about the connection between medication overuse and the increased use of falls. So thank you so much for that. Really quickly, before we get to questions, just want to mention Johnson Insurance, one of our sponsors for MUNalum 101. Johnson offers Memorial University alumni specially designed policies and preferred rates on home and auto insurance, as well as travel insurance. So there's a number there that you can call or visit the website. We've got lots of questions and we have lots of comments saying thank you so much for such a great presentation. So that's wonderful. So let's go quickly to some questions. Trudy wants to know, at the clinic, her dad is 84 and she is his caregiver. So would the clinic prefer to see us both or just him or just herself as his caregiver?
Yeah, I mean, we would be happy to see either, kind of whatever way is best. If you are the caregiver, we often encourage people to bring along a caregiver or someone that may know a little bit more because it always kind of helps get the full story. If there's someone that's kind of caring for a patient, we'd certainly be happy to have a caregiver involved in the appointment, as long as it's okay, of course, with your dad.
Great. Um, Linda wants to know, why are older women more likely to be prescribed risky drugs? Great question.
I know. Well, that's a good question. And part of me just kind of reflects on it. And I think that sometimes women are more likely to seek medical advice. Like, I think sometimes just in general, they're more likely to go to a doctor if they're, or go to a prescriber and to seek help for any medical condition. I think some conditions are more prevalent in women than men, but I'm not quite sure of the answer. I've often, pondered that, but I think it might be just a function of women see, medical professionals more often.
Right. Rosemary wants to know, do you think there's value for older adults in taking calcium and vitamin D supplements?
Yeah, and I think it all depends, of course, on risk factors. So there's some medications that actually can cause issues with bone absorption and resorption and can weaken bones over time. So particularly if you're on medications like that, oftentimes you hear vitamin D should be in our water here in Newfoundland because we don't get a lot of sunlight and we need vitamin D or activation through sunlight in order to really get the best bang for our buck in terms of the vitamin D that we get in our diet. So there's definitely a good opportunity, or a good value in seniors taking calcium and vitamin D. However, it's not necessary. It's not necessarily recommended for everyone. Too much calcium can cause issues with the heart. If you get a lot of calcium in your diet, you may not need to take the supplement. So again, we like to take a more personalized approach where we kind of ask about diet, ask about history in terms of medications that may cause bone issues, and go from there.
Mhm. Um, Here's a question. It's kind of a general question from Kay, wondering how effective is long-term antibiotic use? I guess it depends on the patient, but
Yeah,
over
certainly
to you.
depends on the patient. I'm sure you may have seen like Choosing Wisely is another group that's looking at appropriate medication use, and they do a lot about advocating patients on not overusing antibiotics. And there are some instances where people will need long-term antibiotics to prevent recurrent infections, but again, it's more of a personalized approach.
Yeah. Sharon has a question, or I want some clarification around PPIs and low levels of magnesium. She's asking, am I correct in understanding that taking a PPI for a long period of time could see a side effect of leg cramping, etc.? And instead of taking a magnesium pill, there could be a correlation to the PPI. If that makes
Yeah.
sense.
Yep.
Yes.
I think absolutely. I think sometimes leg cramps can be a result of low magnesium, and we know that PPIs actually can stop the absorption of magnesium from your food because your stomach needs to be acidic to get that absorbed. So there can be an association there. It's more so like the known link is that it causes low magnesium levels in the blood, and I think some people can get low leg cramps at that with that issue. So can certainly be a relation there.
Um, just really quickly, here's a comment from Nancy who works in long-term care, and she says we are heavy on deprescribing and on inappropriate meds. The presentation was amazing and true to their practice.
Awesome.
Maria Clark says, excellent presentation. Here is a question. Sherilyn wants to know, does ASA help women? She's also heard that it only helps men and hasn't been
Oh,
proven to help women. So,
yeah, no, I think it is certainly effective for preventing cardiovascular events in both men and women. We used to, our guidelines used to recommend baby aspirin or 81 milligram aspirin for anyone kind of over the age of 50 with high blood pressure to prevent a first heart attack or a stroke or anything like that. But now the guidelines actually say not to use it in people who haven't had a heart attack in the past. We just use it in people that had an event to prevent a secondary one. So, if that's something that you want to learn a little bit more about and whether or not aspirin is recommended for you, I'd be happy to kind of make an appointment and look at it individually.
okay. Peggy wants to know if melatonin would have potential issues in terms of interactions, because she believes it's being used more and more commonly.
Yeah, absolutely. I said if I could do one thing in this lifetime, it would be come up with a sleeping pill that doesn't have any side effects and that works because unfortunately, even melatonin does have side effects. So if you're using melatonin for sleep, there is associated drowsiness and everything. Of course, that's often why people are using it, but it can carry on throughout the daytime when you don't want to be drowsy. And if you're combining that with other medications that cause drowsiness, there's certainly interactions there and that the drowsiness can kind of stack up. So again, certainly something that we could kind of work with someone on.
Great. Kathy, can you give me the number again for the clinic? A lot of people are asking for it, and I know it's in the presentation, but
Yeah,
they just
so it's yes,
I
eight
can put it in
six.
the chat.
Okay, perfect. It's 864 two
Yeah,
two seven four.
864-2274.
Yeah, so and
Oh,
of course you can leave a message with a callback number if you don't get a hold of us right away, but that is for our admin assistant and she'll be able to book an appointment with for you.
I predict your clinic is going to get a lot more busy. You might have to put on some more pharmacists after this
I'd be
participation.
happy too. I think, for a long time as a community pharmacist, I'm on the other end of the counter where I'm dispensing all these medications. And of course, we love to have the discussions with our patients at that time. But I think in a lot of a lot of the times the opportunity isn't there to have these, full hour long conversations at the pharmacist counter. So I'm happy to see whoever needs it.
Awesome. Well, I just think obviously, I mean, we had such great participation in terms of questions. If anyone has one more question, we could probably fit it in, but I think it might be time for us to wrap up. I have put the number to the clinic in the chat. Once again, I would like to sincerely thank Dr. Kathy Balsom of the School of Pharmacy's Medication Therapy Services Clinic for explaining what we can do to ensure our medications are serving us well and how to be proactive and be a proactive member of our own healthcare team. Kathy, are there any final words you'd like to share with the audience?
No, no, I think I covered a lot. And again, if anybody has any questions or any, personalized medical questions that they have, by all means, give us a call.
Great. Thank you all of you out there for attending and for your great questions and for your patience about our little technical glitch at the beginning. If you enjoyed today's event, please check out the alumni website for upcoming MUNalum 101s, including one on April the 12th on the supply chain, which I know that we've heard a lot about in the last couple of years and should be very interesting. I just wanted to make a quick note that we have tickets on sale now for a very exciting event on June the 16th. This is Memorial's inaugural Reimagining Leadership Conference. It's a conference about women's leadership happening on June 16th, 2022. And you can visit www.mun.ca/reimagining leadership for some more info or to register. As I indicated earlier, this event has been recorded and we will be sharing a link in an upcoming email. So please keep your eyes on your inboxes. Thanks again to everybody for attending and have a great day.